Good afternoon to all of you on the East Coast, and good morning to you if you are on the West Coast. My name is Jose Leon. I am the Clinical Quality Manager at the National Center for Health in Public Housing, a project of North American Management. I want to welcome and thank all of you for attending today's webinar. This webinar is being recorded, and the resources, slides, and other materials will be emailed to you after the webinar has finished. At the end of the webinar, there will be a question and answer session. And I'd like to get started and introduce our speakers for today's webinar. Jennifer McDaniel is the Deputy Director at Health Center Association of Nebraska. She's a graduate of the Community Health Center Executive Management Fellowship from the University of Kansas, and holds two bachelor's degrees in health education and promotion from Brock University in St. Catharines, Ontario, Canada. Prior to joining the Health Center Association of Nebraska, Jennifer was a CEO and a FQHC in Iowa and FQHC lookalike in Arizona. She began her career as a health educator, leaving her native Canada for a rural FQHC in Missouri. Her work in spearheading the health disparities collaborative led to her being a national speaker at the HRSA Rural Health Association. She is also a BPHC HRSA grant reviewer and HRSA consultant. She is bilingual in Italian. And our second speaker is Kenny McMorris. He is the COO of Charles Drew Health Center in Omaha, Nebraska. Since 2009, he has worked hard to oversee daily operations that include 125 employees, 13,000 patients, and 40,000 outpatient visits. Charles Drew received public housing funding in 2012 for 4 locations. Kenny holds a master's in public administration from the University of Nebraska and is a member of the American College of Healthcare Executives. He is also a certified professional training for NextGen. Without further ado, I would like to turn this over to Jennifer. Good afternoon, Jennifer.
Good morning and good afternoon, everyone. Thank you so much, Jose, for introducing both Kenny and I. We are both excited to be here and present. So we're going to talk a little bit first about the Community Health Center Board of Directors and how to build an effective board. Jose did tell me that in January you had a in-depth discussion about program requirements 17, 18, and 19 for board governance. So I wanted to do a little bit, something a little bit different this time, and as well, being a HRSA consultant, my role within the consulting field is I am the admin governance to go out and do operational site visits. So I wanted to provide a little bit of insight of what we're seeing from a HRSA perspective and some things to improve on. So this is just a little bit, 2 really great resources. HRSA also has a board governing handbook, and then as well NAC has a book called Governing Board Responsibilities and how to do them. And those are really great resources to hand out to your boards. So pretty much the history of the community health center movement, we know it started in the 60s. 150 community health centers were established in the 70s. And that really we've had tremendous growth since 1995. We know with the Affordable Care Act, President Obama really does consider the health center program part of his health care reform strategy. In 2013, we've had more than 1,200 health centers with more than 8,000 locations. And as of September, we've had an additional 25 new access points, and as of last week, we've added another over almost 290 new access points. So really, the health center movement is very successful. So the first part we will talk about is how to build an effective health center board. So really, why do we need a governing board? Like any business, we really need to govern the corporation, and pretty much HRSA says that you need to have a board when you are a federally qualified health center. So it is the law. So what does it mean to govern? First of all, it means to define and preserve the mission. And this really would entail having your board members know your mission and govern with it. You know, it's one thing to be able to recite the mission, but do they actually believe in it? You know, are they making decisions with keeping with the mission and vision? And, you know, and lastly, when an organization has a mission, the goals and objectives really that are set can make that mission possible. And as well, when you have a clear mission and vision, the CEO definitely is able to carry out those objectives that the board would like. Number two, the board of directors will make policies. These are 4 areas that I have seen that board members will make policies. So you have your personnel, financial, clinical, quality improvement, operations. There probably are more, but these are just the 4 main ones. And it's really important to note that a procedure explains the way a policy is carried out. When I'm out doing operational site visits, I will look at policies that really are not approved by the board. They just have procedures. So we want to make sure that a policy is signed and approved by the board of directors. A procedure is the policy just being carried out. They also need to safeguard the assets of the center. We know that the board of directors has a fiduciary responsibility. This correlates to program requirement 17. So really, does the health center and their bylaws, does the board of directors approve the health center grant application and narrative? Is the annual audit approved by the board of directors? And if there are findings, does the board approve an action plan on how to address those findings? So these are just then as well some of the assets that the boards will safeguard. Number 4, select and evaluate and support the CEO. We know that the CEO is the only employee of the board of directors. I really would like to stress that. The medical director, the chief financial officer, the COO, CIO, they are not employees of the board of directors. So really the CEO needs to have a clear job description, definitely have an annual evaluation, and really the CEO needs to be evaluated based on what the CEO and the board decides. I have seen instances where I go into site visits and we have a board that perhaps is not happy with their CEO, they're not happy with what they're carrying out or what they should do. You know, my first question to the board is, what is in their job description, and are you evaluating and setting clear expectations according to what they set forth? And you know, the relationship between the board and the CEO is very unique, and so the board really needs to trust their CEO, which is their employee, to do his or her job, no matter if it is difficult. The board also needs to monitor, evaluate the center and board performance. So if they don't do this, how do they know if they're meeting their mission? And these are just some of the reports that you can look at to evaluate the performance. So maybe looking at clinical, looking at UDS reports, maybe some financials. And also, how does the board think that they are doing? A suggestion that I do have is to make sure that the board maybe perhaps have their own goals, which is separate from the center goals. So maybe you want, the board would like some training on, you know, HRSA 19 program requirements. Maybe they want to learn a little bit more about how to read a profit and loss statement or a statement of operations. Maybe they want to learn how to be more effective in committees. So this can only be done if they evaluate themselves. And also strategic planning. And this bullet is really important because the board of directors really need to plan for the future. And the strategic plan needs to fit within the mission and vision. So perhaps the board is looking at, you know, doing some type of expansion or adding services. You know, that really can't happen without planning for it. So when the board is prepared and they have like a roadmap, so to speak, they are able to make realistic decisions. You know, sometimes maybe a decision may be tough. Maybe you're looking at downsizing or closing a site. So whatever the case may be, you really need to have a really good plan and also an implementation plan to help guide these decisions. So what is the job of a board member? So we have 3 duties here. So number 1 is the duty to care. They really need to be prudent when making decisions. You know, we definitely want to avoid contracts or other decisions, you know, that maybe could harm the health center, and really need to be, these decisions need to be weighed and taken seriously. You have the duty to be loyal to the health center. Program requirement number 19, which is conflict of interest. I have been asked to add 3 slides on this. This is, the conflict of interest has come up numerous times on our site visits, so I wanted to make all of the FQHCs prepared if you are planning to go through an operational site visit of what the consultants are kind of looking for. We know that the health center has directors and officers of insurance, but we never want to make sure to do anything on purpose that could harm the health center. And you know, those things have happened, so we want to make sure that we do our due diligence. And lastly, the duty to be obedient. You know, sometimes during board member meetings, it's important really to ask questions or clarifying questions if you don't know something, because this is essentially where decisions are made. And I've heard some examples just and seen recently where, you know, the board will come together, make a decision, they vote on it, but then there are some rogue board members who will go out into the community and may not agree with the decisions or just say something inappropriate of what's gone on. So we want to make sure to that board members never display this type of behavior. It's definitely unprofessional and not appropriate. So part 2 is the nuts and bolts of board membership. So these are just the 3 goals that we will have to looking at increasing board teamwork and effectiveness, maybe how a board should run, and then there really is some correlation between center effectiveness and how well and efficiently the board operates. So really, let's look at board size. So really, it has to be appropriate to meet the mission. We know that HRSA says between 9 and 25 members. How you decide with the number of board members you have really is up to the health center. These are just some guidelines. You need to represent all segments of the community and definitely have that necessary expertise. So maybe you have someone that has a finance background, medical. If you have public housing or migrant funding, you want to make sure that you have someone that can represent that patient population. The next couple of slides really just talk about and correlate to the 17, 18, and 19 of the program requirements. So really, you know, what does HRSA require from FQHC boards? And so for those health centers that have migrant, homeless, or public housing funding solely, they can apply to have a waiver. And so what that means is that they can waive some of the HRSA program requirements. So if you are approved with that, the entity really needs to explain how it will maintain the fiduciary and operational responsibility. And so for those that don't have a waiver, these are just some of the requirements that HRSA that you need to have for your board. So really what constitutes a consumer is someone who uses the health center as their primary care provider within 12 months. It can be medical, dental, or behavioral health. A flu shot or just going in for a flu shot is not considered a visit. And then the user can also be a guardian or parent of a minor child. The board really needs to represent the demographics of the service area. So, for example, if you have a health center that has 3 different counties, you know, if someone from that county represented, as we stated earlier, if you have a needs assessment and your data supports you have a high percentage of maybe Hispanic patients or public housing funding, you know, do you really have a board member who represents that patient population? And then lastly, I have encountered this and on my site visits, I have seen where the mother and daughter are on the same board, a husband and wife, and also siblings. So this really, you need to keep this in mind if you sit on a board of directors that employees, spouses, or other relatives cannot serve on the board. So really, here's the million-dollar question. I get asked this all the time, and I wish I could have a definite answer, but really, I don't. So where should board members come from? Who picks board members? And, my answer is always, what is the health center's policies? What do your bylaws say? The board should have a board member recruitment plan, a recruitment and retention plan, some ideas on how to find board members. It could be maybe your clinical staff or providers that know someone or patient that may be interested. Your frontline staff members or patient advocates, they probably know someone since they've had the most contact. And I know that Kenny will probably touch a little bit about this. And so when someone is identified, the name should be given to the nominating committee and go from there. And then lastly, does the board have a position description? So if you have someone that is interested, do you have information for that person about your health center, about your board? What does a board member do? Rules and regulations. Do you have something in there about the 19 program requirements? Board member tenure, so there really is not a program requirement or HRSA requirement as opposed to board member tenure. These are just some best practices that I have listed. If you're going through an operational site visit, and I can provide Jose that guide, it is on the internet, you have Part A and Part B. And Part A is program requirements, and Part B is performance improvement. This board member tenure is on Part B. So I just want to make sure that if you're having a site visit, the consultants cannot recommend a condition on board member tenure. It would be a performance improvement. So you really need to have, again, a position description. And then if you have a board member that does not come to the meetings, you really need to have something in your bylaws that states, how you can remove a board member. So I added 3 slides on conflict of interest. This is program requirement 19. It has become a huge area of concern for HRSA. All of the site visits that I have been on, this is the one that I see the most that are not in compliance on. There really needs to be a conflict of interest policy for board members, employees, and consultants, and even vendors. And that needs to be signed every year. The next 2 slides I took out of the HRSA site visit guide, and this is verbatim, word for word, of what the site visit guide that says that the policy needs to have. So just a couple of general comments that I have, because the program requirements don't really specify background checks on board members, but I would like to make a recommendation or talk about that it would really behoove FQHCs to check that board members, staff, contractors, and vendors have not been excluded or debarred from the OIG's list of excluded individuals or entities, and also look at the GSA's list of parties of debarred from federal program. I was at a corporate compliance conference 2 weeks ago, and I had heard of an example where an FQHC recently hired a CEO, and the board never checked to see whether the CEO was on any of these lists. And so they had an annual audit, and lo and behold, the auditor checked, and the CEO was on one of these no-fly lists. So this is very serious, something that really needs to be looked into. This last one, I know that FQHCs and even the board have policies and procedures surrounding the issues of accepting maybe some gratuities or anything monetary. You just want to make sure that the contracts that you're entering or you're agreeing to as a board, you're not done via coercion. Perhaps an example would be, let's say someone offers you Super Bowl tickets, or I'm Canadian, so maybe someone gives me tickets to the Stanley Cup, to the hockey game, for an exchange of perhaps using a certain vendor. So definitely this is very important that conflict of interest really needs to be looked at and maintained. The next couple of slides just deal with the different positions on the board. Obviously we have the chairperson. This individual, promotes teamwork. They act a liaison between the CEO and the rest of the board. They really work closely with the CEO. They do have a close relationship, If you are a member of the National Association of Community Health Centers, they actually have a CEO and board chair workshop that you can attend. The chairperson, him or her, will facilitate board meetings, and then they will assign other members to committees and delegate the tasks. The vice chairperson, this individual, can conduct the meetings if the chairperson is away. They can take on special assignments. They can constantly stay abreast of current issues. And then if something were to happen to the chairperson, they can step up and be the chair. The secretary of the board, they can keep the minutes. These are legal documents. Board minutes need to be signed and dated. When the consultants come on site, they will look at the past 12 months of your board minutes. I have known some of my colleagues to look at the past 3 years of minutes, so it really does depend on the consultant. The secretary can also keep attendance and provide meeting reminders. The treasurer of the board, they really ensure that financial records are kept. They will probably have an active role in the audit. They will work within the finance committee. They will usually chair the finance committee, and the CFO would definitely work closely with the treasurer. These are just some standing committees of the board. These are the ones that I've kind of seen it. Actually, my comment would be, what do your bylaws say? There are definitely some different committees of the board, but the most common ones that I've seen are the Executive, Finance, Personnel, and QI Committee. They are there. Perhaps you may have an ad hoc committee, so maybe something like a nominating, a grievance, a CEO search, those types of things. You can pretty much have different types of committees. So how do these committees work? All the board work takes place within the committees, and then at the board meeting, the committee chairs can report and make recommendations to the full board. You need to remember that policies can only be approved by the full board and not by committees. The other thing I want to just make a comment on is you really need to avoid rubber stamping. I've worked with a lot of boards in the past that maybe some people may feel inadequate. They just don't want to say anything that they don't understand. So really you need to make sure that your board members really do understand and are comfortable with making decision and understand what they're voting on. And that is very important. So you have the Finance Committee. They usually meet monthly. They will usually meet before the full board. Sometimes they'll even meet on the same day. And you don't have to have a financial background to be on the Finance Committee. It's just a desire to learn and understand and ask questions. When I'm out at the site visits, this is the committee that I have most board members tell me that they don't want to be on because they don't understand. And so it really is sad because they just need a desire to learn, and maybe that could be part of your board goals for the year, is to learn a little bit more about finances and how to read some of the reports. So the reports can be prepared by the CFO and reviewed by the CEO, and then this is whatever your board packet or what you provide to your board with regards to financials. This is what the committee can then provide to the full board. And then in the next couple of slides, I just threw in some what your report package could look like. So maybe you have a narrative, you look at your profit and loss statement, a cash flow, maybe your balance sheet, and maybe some other statistical data. So maybe looking at your payer mix, you're looking at your new versus established patients. So really there's nothing set. You can add and delete these as time and situations change. And then you could even add a few things on accounts receivable if you like. So, and then there's also the clinical and performance measures and business measures that HRSA puts out. So the next committee would be the Personnel Committee, and they can review and update personnel policies. They will look at position descriptions. Maybe they will make recommendations regarding positions. So it's not the actual person that they're looking at, but the position. And if you want, your Personnel Committee can also serve as the Grievance Committee, and if it's specified in the bylaws. Again, the bylaws They're essentially your Bible on how health centers run. Then you have the QI committee. I know that HRSA has done a lot of work with our Quality Improvement Committee, especially when it comes to the Federal Tort Claims Act or your federal malpractice. This can be chaired by a clinician with appropriate experience. You definitely can have a board member on your QI committee. That's something that I recommend. You can review things such as, peer review, patient satisfaction, clinical performance measures. Pretty much you can do your PDSAs, your Plan, Do, Study Acts for your workflows. So this would all work within the committee. Board meetings, they're usually, they can meet monthly with minutes kept. You have annual meetings. Again, minutes need to be signed and dated. And then you can definitely use your Robert's Rules of Order. And anything, again, it's specified in your bylaws. So really, what about outside relationships? So how does the board deal with the community, health center staff, and other funding agencies? So pretty much the community connection. The board definitely has a role in that. Every member is a spokesperson, especially what about community development? Are you working on a capital campaign to add an additional building or doing some expansion? I know that that's something, being a former CEO, I really wanted my board to help with fundraising. And it's essentially is easier, even if your board, each board member contributes $1 or 50 cents, going out into the community to say, we have 100% contribution from our board, it really just speaks volumes and really does promote the mission and vision. Again, it's not required. I just want to put that out there. And they can also establish and foster linkages. This one, ironically, has come up this morning that I've been talking with some of my HRSA colleagues. What is the relationship with health center staff? Or especially since the CEO is the only employee of the board of directors. Essentially, the CEO is the link between the board and the rest of the health center staff. The board of directors really need to have a high level of trust and confidence in their CEO to make sure that they can fulfill the requirements. It can also become a general problem if general staff members start interacting with board members individually. There have been instances maybe where staff may ignore the chain of command and go straight to the board if they have complaints about their current positions. I am not talking about perhaps some extenuating circumstances, but what I'm saying is that clear boundaries really need to be established. The board's role is oversight and not day-to-day operations. So information on the day-to-day should come through the CEO. What about relationships with outside funding? So these are some areas that maybe your board members can work with, your local and state government. What about your senators, your state representatives, the private insurance companies, your federal government? So there really is a lot of outside relationships. And I just wanted to list a couple of external advisors that maybe you can turn to if your board of directors, or if you're a board member yourself that your CEO can reach to. Your primary care association most definitely can help you. There are other health centers. NAC does a lot of work with board governance, board training, things like that. There could also be other agencies. So lastly, how to build a community health center. This is really how does it work for a board? So really this correlates to program requirement number 1, which is a needs assessment, and it really sets the tone for how the board operates in providing oversight of a health center. So needs assessment drives everything. Are you looking to expand in other counties? Are you looking to add chiropractic services or maybe dental services or behavioral health? Maybe adding some migrant or public housing funding. Your needs assessment will drive everything, and that's really what you need to do, and that's what a board needs to look at. And then how do you meet those needs? You really need to look at your provider staff, looking at patient-centered healthcare home or patient-centered medical home. How are you physically designing your space? What clinical support staff. How many providers do you need? Do you need mid-levels? Do you need, PAs? And then really you need to calculate a realistic budget and realistically project income. So, and look at your payer mix. So if you have a high percentage of uninsured patients and you're thinking, wow, this year I'm going to, get 90% Medicaid and I'm going to project based on that, is that really realistic? You really need to make sure that you are projecting realistically. And then what is out there? Determine grant or legislative funds available. We just went through a round of new access point funding. We potentially could have some additional capital funding. So those are just some things out there that you need to have your ear to the ground. And then lastly, you need to operationalize it. So, this is where the board directs the CEO and his or her staff. Provider recruitment and retention. Again, do you need dentists, mid-levels? Are you a National Health Service Corps site where you can do loan repayment? So these are all some of just the areas that you could look at on operationalizing your health center. And then lastly, you need to have the staff to support your providers. Do you have enough clinical individuals, billing, front desk, that type of work? So that concludes my part of the presentation. I am going to turn it over to Kenny McMorris, and he will talk about how to recruit some public housing board members.
All right. Well, thank you very much, Jen, and thank you, Jose, for that wonderful introduction. Just wanted to share with everyone kind of our experience with our implementation of the public housing program that we were awarded in 2012 and the board member process, and then also shed a little light and kind of reiterate some of the things that Jennifer had mentioned because we do find it very valuable in our day-to-day life in which we're operating here at Charlesville Health Center. We were lucky enough or fortunate enough to receive funding in 2012 to operate 4 public housing locations. Omaha is relatively unique in which we actually have high-rise or towers, unlike some other cities that have kind of demolished a lot of those and they've moved more to scattered sites. But Charles Drew, or at least Omaha that is, has a couple of high-rise where we have residents that reside in those towers. And so we submitted a proposal to take care of this vulnerable population in which we know that a lot of them are using the emergency room or basically going without care in terms of seeking their health-seeking behaviors. And so we embarked on this endeavor last year, and really from our standpoint, it's definitely been a lot of growing. We were fortunate enough to talk to a number of partners across the country to look at best practices, to see what worked for them and what didn't work for them. And in our case, we've had a couple of bumps in the road, just like anything else when you're starting, I would call it a new business, if you want to call it that. But we've had some pretty good successes here. One thing I would like to mention and talk about in particular on the board recruitment side, let me take a couple steps back. Charles Drew, we're fortunate enough to be very diverse in how we're serving our patients. We do receive funding for public housing. We also receive funding for the homeless population, and we receive funding for capital improvement for school-based health centers. So as our operations kind of have evolved over the last 3 to 4 years, we really look at our programs across the continuum and say that we're really trying to cover the entire family and the entire community in which we serve. And so the public housing aspect in terms of getting the recruitment process was one in which we spend a lot of time with the housing authority, and that they know their residents better than anyone else. And so we had a series of meetings that started and continue to really get a better understanding. What is your future vision? What are your goals? And how best does Charles Drew help you improve the health status of your public housing residents? And so they've helped us out with trying to identify key people that really truly have a pulse of their residents. Each of our towers do have a resident council, which is led by actually they have a governing structure that has a chair and vice chair and secretary, and that we were fortunate enough to identify someone from one of our resident councils to kind of serve on our board, the Charles Drew Governing Board, that is, to be the voice for that population. Interesting enough, this individual was already a patient at Charles Drew Health Center, and so that they had an experience with being with us for a number of years, and it was good to be able to bring that service to that particular tower in which this individual is able to participate in. And so we were fortunate enough as far as that goes. Now, the unique thing is, in some cases, there's a length of stay within those particular. Some housing authorities have a time limit on the number of years or the timeline in which individuals can be residents of their housing authority. So you must kind of consider that. What would the turnover be? What would that process look like in terms of recruiting a new person? And Jennifer did mention your bylaws. Your bylaws, in essence, as she mentioned, is your Bible. And so use that as your guideline to help recruit the best individual that could help represent the population. Some of the challenges that we have, I'll touch a little bit about that, is that, again, it's really trying to, because of the population is so transient, being able to get someone that truly represents that population and understands what's going on, but also making sure that person has a pretty good understanding of what's going on with the leadership within a housing authority. As I said before, the resident councils were excellent for us because those individuals had already had a working relationship with the leadership of the housing authority, so that made that transition that much easier for us. The other thing is just really understanding the population. As you all know, when you're submitting a proposal, you do need to do a needs assessment and looking at, okay, what are the needs of this particular population. But we held a number of focus groups that were ever evolving and ever going. So we started off with what we needed to do per the grant requirements. But then as time went on, we found that this was the best way to really communicate to the population. So not only do they have their regular resident meetings, but we also hold a separate meeting to engage them as well, to really find out, okay, well, what do you like to see? What is working? Are you happy with the dietitian that we're bringing to you and providing services? Are you happy with our monthly behavioral health meetings? And so having a pulse of that population and your board representative can help facilitate that is critical and is very important. The other thing is making sure you have competent and capable staff. And Jennifer had mentioned this as the role of a CEO. Your board is charged with setting vision, but as a CEO, you're responsible for identifying strategy, allocating resources, and then hiring the best staff you could possibly find to carry out the mission of the organization. And so it's important that depending on which model you use, if you're using a nurse practitioner or physician assistant model, or if you're using an MD model, that you get someone that understands the population. There's nothing like having a provider there that will be great clinically, but if you don't have a level of compassion and a level of understanding of the population, you will have some challenges with getting things off the ground. What we like to call it is the likability factor. As you know, this population is very unique in that if they do not feel comfortable with you, if they do not feel as if you're one of their own, as if you're one of their own, then they're not going to seek the services that you're providing. It will completely undermine everything that you're doing. So make sure that you get competent staff that have a level of compassion, that understand the community, to make sure your program is that much successful. Again, the representative from the board, as well as relying on your residents' council, can help facilitate that. What we're finding is word of mouth is the best way to do any type of advertising in terms of this programs and services. So really getting them to understand and talk to the residents about, yes, I went in today and they're helping me manage my chronic conditions, or I went in today and got a physical and they identified a couple things. It's really important that the residents can speak that message for you because that's how you're going to get individuals to use the services that you have. A couple of successes that I'd like to talk about. We've been fortunate enough, again, as I mentioned, having a solid board member helps out. The resident councils have been great. But again, the monthly meetings have also been phenomenal for us. We've been in situations to where we'll have a quick raffle in which we'll get some toiletries, things like that we know the individuals would need, and we'll raffle it off at the beginning of the meeting or after the meeting to kind of talk, and we use that as a way to talk to them about the programs and services that we're offering. Again, this population in a lot of cases have not seek health care or believed health care or went after health care as a primary focus for them. And so in our city, Again, a lot of them are using the emergency room, and we're more reactive rather than proactive. And so it's important that you try to do a lot of education on the front end to help them understand the importance of staying healthy, the importance of eating properly, and the importance of really taking care of yourself. Like I say, if you don't have your health, you don't have anything. So your health is your wealth. And so a lot of education needs to occur, and just meeting them where they are. I mean, again, in some cases you have some people that we have residents that, quite frankly, actually have advanced degrees, and we have residents that don't have anything higher than the 5th or 6th grade reading level. And so you got to make sure that the staff understand that. You got to make sure that your programs are geared towards that. But again, just making sure you're being respectful of the population in which you're serving. Again, you want them to embrace your health center. You want them to embrace the services, not to fight against you in terms of the health care. Couple of other things just want to touch on and reemphasize some of the things that Jennifer had mentioned, is that the conflict of interest is important. Again, making sure that the board overall and the individuals that are on the board understand their role and responsibility. Again, it's far too often that you'll get board members that get away from the governing and want to get really into the operations of the organization, and that's not where the board needs to be. Again, you're setting the vision, you're setting the mission, and then you're holding the CEO accountable for, again, allocating the resources to carry out that mission. So making sure that the board clearly understands, you have a signed conflict of interest statement by each board member that outlines exactly what their role and responsibility is as it pertains to the organization. Another thing is know your data, know your numbers. Again, it's one of those in which you want to make sure that a lot of the work is happening at the committee level. And so an informed board is a better engaged board. You want to make sure that you have information that they truly can look at a snapshot of the organization and be able to identify, are we really doing well? Some of those board members, or all of them, should have a nice pulse of the community. So they should be able to tie in the data that they see as it pertains to the organization, but also what the community is saying about the programs and services that we're offering. So making sure that your board has ample information and the right information. In cases, some boards have too much information, and that doesn't serve you well. But making sure they have the right information to really get a snapshot of the organization. And then the other thing is making sure that you truly work your committees and looking at your committee structure. Your bylaws should outline all of that. However, you want to stay away from a lot of the things taking place at the board meeting. Make sure a lot of the work happens at the committee level. Have some engaged committee chairs because, again, leadership is critical, and that the staff, or I'm sorry, the board members really go to the beat of the leadership of the organization as well as the leadership at the chair level. So making sure you have you have an engaged chair, vice chair, secretary, and treasurer. That will make your organization function that much better. And then the other thing and final thing is don't be afraid to surround yourself with experts. It's really important, not only from the CEO level, but also the board level, that you get a diverse mix of individuals that truly understand the operations of the organization, understand the pulse of the community, but more importantly, understand the health disparities of that particular community and where the organization should be going. So in a lot of cases, people are afraid to surround themselves with individuals that may know more, have a better level of expertise than what they have. A thriving organization is only as good as the individuals that are part of it. And so making sure that you surround yourself with capable, competent people, that includes board members as well as staff. So with that being the case, that kind of wraps up everything that I have. I think we'll be opening it up for questions here.
Thank you, Jennifer and Kenny, for this wonderful presentation. Now, if you have any questions, please submit it through the question box on your control panel, or use the hand raise icon, and your line will be unmuted. All right, we have one question. Should there be a limited term of service by the chairman of the board?
I think it's, Kenny, do you want me to take that, and then you want to say something?
And I can support it as well too. So.
Okay. Well, why don't you talk then from an FQHC standpoint, and I can talk from a consultant standpoint then.
Yeah. So there should be term limits, and the reason being is one of those in which you want to make sure that you're recycling the expertise. You don't want to get your board chair to be burnt out. You also want to respect their time. To be a board chair is a huge responsibility. And so in order to make sure the organization is thriving, you want to make sure that you're constantly growing. And one way to do that is having a process in place for rotating your board chair and also the other leadership positions within the board, so vice chair, treasurer, and secretary. That would be highly advised to be doing that.
And I echo Kenny's sentiment as well. Definitely your bylaws would specify that. I think it's a great idea to rotate your board chair. Usually it's set in the bylaws maybe every 3 years or every year. I think it also provides maybe a different perspective as well when you are a board chair and you have that role and responsibility.
The other thing I would like to add as well, and it really kind of speaks to where you are as an organization. So if you have a board chair and your organization is in growth mode, or there's a lot of things that are going on, you may get a board chair that commits a little bit longer, but that helps facilitate basically having a good solid infrastructure and having a structure in place to where it gives the greater community an understanding that the organization is on solid ground. So in some cases, the board chair may have to stay on a little bit longer or assume a little bit more of a role, but you really want to make sure that, again, that is being communicated and articulated amongst all the board members that, okay, this board chair is in place right now, but I would like to move on, and we would encourage someone else to step up. So really depends on what's going on within the organization. You don't want to have a lot of change going on at one time because it could send a negative message.
Thank you, Jennifer and Kenny, for those responses. There is one question for Kenny, and the question for you is, just give me 1 second. Sorry about that. Okay. The question for Kenny is, how much time did Charles Drew spend on finding the diverse group of board members?
We spent, it was, how should I say, it was an ever-evolving piece, I would say that. I wouldn't say there wasn't a specific time limit on it. It just kind of evolved. We knew that we had to have a representative from that population just because, again, we've had our homeless grant, and then even from our school-based, we have a parent on there that represents a student that we really relied on our leadership from the Housing Authority, and again, those resident councils were critical for us. And so, to be honest with you, it really wasn't that hard. It really wasn't that difficult because we had some really engaged, and we set the foundation a lot early. Really talking to them about the expectations, what is truly the commitment. And our structure is one in which we have a monthly board meeting, but then they're also required to commit to 1 or 2 subcommittee meetings. And so we do a pretty good job of doing the board orientation. We set the expectations a lot early. And I give credit to our CEO as well as our board chair on what that looks like. So we send all of our board members through an orientation process. Then also we're fortunate enough for the new board members to send them to the board member boot camp that's put on by the National Association. So we do have a pretty elaborate process on board member recruitment and retention. But in this particular case, we were fortunate because we had some really engaged resident councils.
Thank you, Kenny. And we have one more question. Well, how are members of the resident council selected?
So we have a nominating committee, and again, our bylaws kind of outline what that looks like. And so there's a nominating committee that's made up of our Charles Drew board, and then we kind of go through an interview process. So Individuals will submit an application, kind of include why they want to be a part of the board and what expertise they can bring to the board or what value they feel they will have. And this is all part of their application process. The application is then received, it's reviewed by the CEO and the nominating committee chair. And then from there, they take a look at to see who would be the best candidate for to represent this population. Each individual is given an interview, and then based on their paper application and interview, then we will identify which individual will serve to represent this population. We still keep one or two people kind of waiting in the wings, if you want to call it that, just to let them know that, hey, you were not selected. However, if something was to happen, you would be the next choice, just in case someone, the individual can't make the commitment over the first few months. And we haven't had that happen just yet, but it's one of those things in which you need to be looking for just because of the turnover within a population. Again, our housing authority is one in which they're trying to transition a lot of the families to permanent housing. And so they have a tenure stay that's wrapped into their lease agreement to try to not keep individuals there for a long period of time. So making sure that you have a couple options, really going through your bylaws and making sure your bylaws kind of outline that process, but relying on that nominating committee to find the best person to represent the population.
Thank you, Kenny, for your response. We have some more questions. Do you have or do you know of any training materials on leaderships for residents?
I don't know of any per se, and Jen may be able to speak to that. But one of the pieces that we do in terms of our board development, we do have some leadership development training as it pertains to the role of the board. And so kind of from there, the individual may be able to identify some other areas and where they may need some development, and then we'll kind of see what works best or what resources will be available to allow for that. But I do not know of anything offhand specifically on that piece.
I don't either, Kenny, and I can put it out to some of my colleagues if Jose, if you want, so just let me know.
Right.
And then one other thing, too, I mentioned before, the new board member boot camp that's held annually by the National Association of Community Health Centers does have a piece in it that speaks to board member leadership overall, but more importantly as it pertains to being a board member, so that can help also as well.
Thank you, Kenny and Jennifer. We have another question. Can PCAs recommend individuals to serve on the board?
No. So the question was, can primary care associations
recommend individuals? Yes.
Individuals. I don't think so. Kenny, your thoughts on that? I have not seen that.
Yeah.
Can refer someone, but it really has to be within that, service area, or if they're serving that patient.
Yeah, I agree. I think it's more about the referral rather than, if we can use terms, recommend. Again, the process, as I outlined before, in terms of the nominating committee, and that process still needs to hold true no matter who represents or no matter where the referral is coming from. Again, you got to remember that that individual has to represent the population. And so I could feasibly see that it could be a recommendation that comes from the PCA because they may know someone that lives within in that particular group. But ultimately, it still needs to go through the internal process that's outlined in your bylaws.
Thank you very much, Jennifer and Kenny. And there is another question besides doing background checks. What other information or files should a health center keep on board members?
Well, I'll take one piece of that, and then of course, Jen, you can chime in. Of course, we got to understand that there's that 50 plus 1% consumer requirement, and so naturally, depending on if you got a consumer, and we're talking about consumer board members here in this case, of course, we'll have their medical record and so on and so forth. But remember that there's a level of confidentiality that needs to occur with that. The other thing is we do background checks on our particular board members, so that's another file that we keep. But really outside of the application that they submit to the organization, upon seeking to become a board member. That's the only thing that we keep on. Of course, we'll keep in board member insurance and so on and so forth. But really, from our standpoint, there's only a couple items that we keep on file as it pertains to our board members.
And I tend to definitely agree with that. You want to make sure that their information is definitely protected. And the same thing, just a board member, if they fill out, an application form, their confidentiality statement, maybe if they're choosing different committees, you could have their recruitment and retention, their annual evaluation, that type of stuff.
Yep. Also the conflict of interest as well. So.
Yes, thank you.
Yep.
Thank you, Kenny and Jennifer. We have another question coming in. How do you handle situations where board members are repeatedly not in compliance and need to be removed?
Oh, okay. Yes. So that's really, again, where you got to look at those bylaws. And I guess the general theme probably through all of this, and I don't know, Jen, I'm going to speak for you, but organizations really need to spend a significant amount of time on those bylaws. As we know, things are ever changing and ever evolving, and so you want to make sure that those bylaws are current and, more importantly, that they're relevant to what the needs are of your particular organization. However, the bylaws should clearly articulate the process or corrective action process for non-compliant board members. In our particular case, we have a meeting requirement that each board member has to commit to. And then with that being said, then of course if you have a solid and excellent board chair, that person can also have the conversations with those individuals, say basically, hey, we need you. It's important that you're present and you're a valuable individual to this organization. And so the way that you show your value is being present and being engaged. And so really rely on those bylaws to serve as your guiding principle. You don't want to be doing anything based on how you feel. It needs to be based on those bylaws. So making sure that you have a really engaged chair and making sure those bylaws are solid will give you your best bet with dealing with non-compliant board members.
I wholeheartedly echo that sentiment. I've also seen it where the chair of the nominating committee would reach out to that individual if they're not in compliance. If it's, let's say, hypothetically, it's not attending meetings, and that's where you really want to have a strong board chair to kind of reach out. And sometimes board members may not do that intentionally. Maybe, something's come up. So, but again, your bylaws dictate what happens at a board level. And so it would usually, it would come from your board, not the CEO. I definitely would recommend the board chair or a chair of the nominating committee.
Absolutely.
Thank you very much. And this is a question for Jennifer. What resources can you direct an agency toward in order to learn all of what is entailed in establishing an FQHC?
Sure. HRSA, I would definitely reach out to HRSA, and I can send that link. They have a, so you want to start a health center. There should be a book, and as well, if they are newly funded, HRSA had put out a, so you're newly funded, since we've had so many as well. Your primary care association, they have a cooperative agreement. That should be, they are there to assist you as well. And then obviously your entity, Jose, they can also reach out to the National Association of Community Health Centers. So there are quite a few resources, and I can send some of those resources to Jose so you can send them to that individual that asked the question.
Great. Thank you very much, Jennifer. There is another question. It says, ours is a migrant health center and as well as a community health center, and some farm worker members are not as fluent in English. Over the years, we have translated documents, have an interpreter at meetings. Can you make any comments on what you have seen among boards with monolingual, non-English speaking members?
And I can speak a little to that. And so we are fortunate in our case, well, I'll say Omaha is a very diverse population. And interesting enough, about 8% of our patient base speaks English as a second language. A lot of those are not the traditional language. A lot of our from Burma and or Somalia that speak a lot of the tribal dialects. And so we're fortunate to have at least one board that does speak Spanish. That does help out with that particular population. But the other thing I would advise in looking at and looking towards, especially for the rural communities that do have a language barrier, if you want to call it that, is to really rely, and I don't know if you all have had a chance to kind of look at the language lines or possibly working out a cooperative agreement with some interpreters to help facilitate the process. We've been fortunate enough that in our area that we do have some contracted interpreters that are skilled in medical terminology and things like that. And so putting a board member on there that does speak English as a second language is definitely an asset. You may not be able to have that, but just making sure you have options for individuals that speak English as a second language could help facilitate the process.
And just to add to that, if you do have a translator, make sure that they have a confidentiality statement and also a conflict of interest.
Yep.
Those are very important.
Absolutely.
Excellent answers. Thank you, Jennifer and Kenny. There is another question for you. Is it a conflict of interest when a board member enters into contract negotiations on behalf of a health center? Shouldn't it be the health center staff, like the CEO, the CFO, or the medical director?
I'll take that one. Yes, it should be the leadership of the organization, meaning the CEO. The board member may get word of someone that's interested in partnering with the organization, but they should not be negotiating contracts on behalf of the organization. That's the role and responsibility of the CEO.
Yep, I agree with that. And that's day-to-day operations. So that's not something that the board is involved in. The CEO will bring it to the board to discuss, you know, especially if it's maybe a Medicare contract or a Medicaid contract, but it is the CEO to do that.
Thank you very much. There is one more question. Is HRSA funding a stable federal source of funding, or is it the FQHC expected to reduce their reliance on funding over a set period?
Well, I would look at it like this. Operationally, you will want to make sure that you got a very diverse source of funding. Depending on what your payer mix, making sure you stay on top of that. As I mentioned before, know your numbers. It's important that you're looking at that on a daily, weekly basis to know what your payer, where your funding is coming in as it pertains to revenue or patient service revenue. HRSA has been great about funding and providing new opportunities, but just like any other organization or business, you want to make sure that you're very diverse and not relying on one particular source to carry your organization. We do understand that this is very trying times, but it's very exciting times as well. So looking at your numbers, knowing what your numbers are, making sure that you're creating the best patient experience, because ultimately you want to try to generate as much revenue as you possibly can to keep your organization staying afloat and minimizing your reliance on support from any federal and state dollars that you may need to receive to operate.
And I too echo that sentiment. I mean, when you look at a budget, hypothetically, they say that, you know, HRSA funding or federal funding should maybe just be 25% of your budget. Realistically, you know, we serve a high percentage of underserved and uninsured populations, and that isn't the case. So you definitely want to look at other, you know, revenue streams.
Thank you very much, Jennifer and Kenny. One more question. Based on the information that was just given, how does a health center go about educating the board on what their true responsibility is, meaning not running the day-to-day operations, but overseeing everything and taking more of a backseat and allowing the health center and its employees to do its job?
So I look at this as a couple ways to approach that. As I mentioned before, it really comes down to leadership. The board chair and the CEO have to be in lockstep. They have to be on the same page. And so looking at spending the time you need to spend on what the new board member orientation process is, or even for that matter, just overall orientation for board members, setting those expectations early and staying the course with that. It's very easy to get off of that, especially when you're looking at the monthly board meetings. It's really easy because people's natural inclination is to get into operations. I mean, that's easier than governing for the most part. So the leadership part of it, the board chair really has to keep the board on governing, on the vision, on the focus of the mission, and allowing the day-to-day staff to deal with the day-to-day operations. So really making sure that you got solid leadership. The committee structure, again, leadership at the committee structure level also is critical because, again, the rest of the board, different board members, their educational level and their level of engagement is going to be relatively different just because you're meeting them where they are, and there's value in that. However, the leadership of each of those committees as well as the board chair are the ones that set the tone and set the structure for how the organization is going to conduct business as it pertains to governance. So making sure that you got solid leadership at the top is critical.
You can also reach out to your primary care association. They probably have done some board training or have put it in their goals or strategic plan. The other thing you can do if health centers want, they can reach out to their project officers. There is training and technical assistance that they can request, and HRSA will send out an admin board governance consultant and will do some board training if that's what they would like.
I'd like to add that is very useful. We've actually participated in that here at Charles Drew, and our board really enjoyed it and thought it was very beneficial. So I definitely will recommend that to the listeners on this call.
And just to add, when you go through an operational site visit, if your admin governance individual recommends board training, they will try and send out the same person. So that way, because that consultant already has a relationship with that health center and the board. So any additional training will be done by that consultant, and then the organization can also request that same consultant to come back.
Okay, thank you, Jennifer and Kenny, one more time. There is a similar question. You may add some additional information. One of our board members think that our governing board is an advisory board and only there to give advice to the CEO. How would you address this thinking?
So I'm not 100. Yeah. So there's a sub-advisory board, or I'm not clear exactly on what the question is asking. I don't know, Jim, maybe you.
I think what they're saying is the board doesn't feel that they have that fiduciary or operational responsibility. And so, to be honest, if something were to happen, HRSA is going to look at that board, not essentially that CEO. And so I think there has to be some type of education and definitely some board training, and even on the part of the CEO. So my question would be, does that CEO condone that, not condone that behavior, but is that what he is leading that board to believe? So I think there has to be some education that needs to be done. So that was my take on that question, unless I'm wrong.
Just adding something, I mean, there's a level of transparency that has to occur as well, and so making sure that, again, it goes back to that the board chair and the CEO's relationship is very critical that the communication happens at that level.
Welcome to GoToWebinar. Web events may.
So the piece I believe they're referring to is that the individual that's representing the public housing population on our board of directors actually goes through leadership training as a board member. So that's the piece that I was referring to. However, I wouldn't necessarily call it leadership we do have some education that we give a lot of our residents because, as I mentioned before, this might be outside of the health scope. We're finding that there's other supportive services that are needed for that particular population. And so we try to do the best that we can to bring in partners that help out with that particular group. But as it pertains to the board role and the leadership portion, we do have some leadership training that's available for the public housing individual that represents that population on our board of directors.
Thank you very much, Kenny. For those asking about the slides and other resources, this webinar is being recorded, and the resources, the slides and other materials will be emailed to you after the webinar has finished. You can also find this webinar if you visit our website www.nchph.org. Now, we don't have more questions. I want to thank Jennifer and Kenny one more time for this excellent presentation. And we need people like Jennifer and Kenny to keep us abreast on topics like the one that they have just presented. To all of the attendees, please complete the post survey. This helps the National Center for Health and Public Housing to improve our webinars. If you have any training or technical assistance needs, please contact one of our talented staff members. Once again, thank you very much for attending this webinar, and thank you to Jennifer and Kenny. Have a good afternoon.
All right, thank you.